Jesse Jupiter. I'm a Hans-Georg Wyss AO professor at orthopedics at Harvard Medical School and a surgeon at Massachusetts General Hospital in Boston, Massachusetts. The basis for this discussion is on a presentation I will make at the Hand Society Specialty Day in a few days. And the title is When Volar Plates Are Not Enough. What that is referring to is the fact that the method of treating distal radius fractures operatively in the past 2 decades has dramatically changed with the advent of new technologies. Prior to that, in bone that was either osteoporotic or weakened from some reason, or very difficult patterns of fractures, it was very difficult to use screws and a plate to hold the bone in place because we didn't have the technology that developed where screws could be locked into a plate. Following that, there were developments that could show that a safer surgical site for placement of the plate and screws was on the anterior or volar side, where there was less problems with the overlying soft tissue tendons and nerves. And that led to a transformative change in the management of fractures. Distal radius fractures are almost public health issues because of the volume. And as a result, there are so many, as people also are living longer, living healthier, we haven't been able to control osteoporosis. So as a result, there are more and more of these so-called fragility fractures. People in the past used to treat most of those with a cast, and we found that to a certain degree there were some associated problems of the hand stiffness or weakness of strength as a result. And particularly in an active patient, there was an increased interest to trying to give them a better functional outcome. So with all of that and this technological development, the worldwide, in developed countries, approach to a fracture that prior was treated often with casts alone was now operative. And the reason that I'm going to talk and have written about the fact that volar plate, this technology, is not always suitable or applicable is because, like many things, there are different patterns, different types of fractures. And when we see more complex fractures, not in the fragility or osteoporotic bone, but rather in higher energy and higher velocity fractures, we see pieces of the joint that are displaced or out of position. And sometimes we can't get a satisfactory repositioning or realignment of those fragments without using additional technology. And so there are groups of these fractures, then we find we have to do additional technologies, either doing our surgery from the top of the wrist rather than only from the bottom, or different types of bone glues or bone cements or additional bone grafts. The other thing that's interesting is you could take this topic and ask another question. Is volar plate, my topic is not enough, but actually you could ask the question, is volar plate too much? Because there's a lot of evidence of reasonably controlled prospective studies that have shown in groups of older age patients treatment with a cast is equal to the operative treatment with a volar plate. And the major difference is there's a higher risk of complications from surgery than non-surgery. So in a way, if you want to look at it like a pendulum, it's sort of now being challenged and swinging back a little bit away from the volar plate, and it's challenging orthopedic and trauma surgeons and hand surgeons to try to determine better means of assessing the patient in the management decisions. That is to say, we have to know more about the patient's activity level, interests, what they see as what they want to get out of this treatment. Many patients who are older age that are less active might say, I don't want to have surgery, I want to just have a cast, and I don't care if my wrist looks crooked. And the evidence that are being accumulated would suggest that there's a good chance that that patient will function very well. Many years ago, I co-authored a textbook on distal radius fractures. It was a whole book, about almost 400 pages on distal radius fractures. My chairman of my department, Henry Mankin, wrote a foreword, and he started it by saying, this is a very nice book, but I don't know why there's a whole book on this fracture. This one fracture where I thought that it's easily taken care of. But then looking through, I realized there are many different aspects to it. However, we're starting to say maybe some patients don't require this volar plate. Again, let me summarize by saying in some instances it's because the fracture itself has a higher energy and is disrupted the joint to a degree that just the volar plate alone would not be satisfactory in keeping the pieces in place. But also there may be a large group of patients that will function very well with just a closed positioning of the fracture and a cast. And a very large study in England looked at many centers, got information, and they suggested that their patients did function very well. So we're really at a crossroads of the role of the volar plate in the management of these fractures.